grateful to be here. Thank you for the invitation. Big shoes to fill, definitely. Clearly, I have poor judgment in that you're always supposed to find somebody who's a complete failure to try to follow, and that certainly was not the case. Dwayne's leadership here for so many years. A little bit about myself. I'd probably start actually with my parents, which is an important part of who I am. My father came to this country in the 1950s from Colombia, South America. And my mother is Iowan. We joke. It's sort of I'm Colombian and Iowan. And I grew up in Minnesota. And right after college, headed east. Very, very strange set of circumstances. Went into my economics class one day and said to my professor, "What do you think I should do?" And he said, "I think you should work for the Congressional Budget Office." I said, "Great idea." I packed my bags. I moved to DC. I got a room in a group house and marched myself into CBO and asked them for a job. And after they were finished laughing, they said, call us later. And I proceeded to call them every Friday for a couple of months. Meanwhile, I got a job at a flower shop so I could pay the rent. And they got so tired of that they hired me as an intern and then full-time. And that is where I started my career. I am married. My husband recently retired from a 35-year career at NASA, where he did near-space exploration. And so the joke is we don't talk any shop at home. Healthcare and space doesn't often come across. And I have two wonderful children. My daughter is 20 years old. She stayed back east. She's at the College of Charleston in South Carolina. And my 15-year-old son, my knucklehead, I love him to death, he made the trip with us right as he was entering high school. So, and then we have a dog.
Oh, a dog.
A dog who just turned 3. So that's a little bit about my family and how I ended up east and now west.
Oh, very good. Well, you clearly have a very full life. You got a very busy home life. You have a very, very busy schedule. When we see you everywhere, right? And you're here, you're there, you're in balancing home. How do you stay centered? I mean, the first time I laid eyes on you, that woman's centered. How do you stay centered?
Isn't that a great question? We should all ask ourselves, how do we stay centered? For me, it's probably a couple of things. Everybody always asks me, you must exercise all the time. All right, here's the honest truth. I haven't exercised in like 22 years. I'm not kidding. Not kidding. I'm not proud of it. But because I think you can stay centered, and I actually believe you can stay healthy up here. And I think it helps me quite a bit. So I guess my first part of centeredness came from a dear friend. She headed the Pennsylvania Hospital Association. One of the few women who was involved in hospital association work. And I said, how do you create work-life balance? This was many years ago. And she looked at me in the eye and she said, just forget that right there. There is no such thing as work-life balance. And don't we all talk about it? And she said it just doesn't exist. She said, when work is busy, you're going to be running 200 miles an hour and focused on work. And when your family needs you, you're going to be running 200 miles an hour and you're going to be focused on your family. But her advice to me was, if you think there's this magical spot where it all comes together, she said, you're going to search a long time to try to find that. So my first piece in centeredness was giving up the notion that there is a magical spot that I'm in search of. And I just try to figure out every day who's in need. I was just joking with Julie. Woke up this morning and we are helping our members with the Feather River Hospital at Enloe Hospital and everything that's going on up there. And then I get an email that our schools are closed today because of the smoke. And as my husband's about to board a plane to meet me at our next destination, I thought, oops, gosh, who's going to watch my son today? So it's just a great example of, you can do two things at once. And maybe my second piece of centeredness grows out of some challenging life experience, but I've really learned to try to set aside those things I can't control. And so I really do focus, where can I put my effort and my energy and make a difference And those things get more than 200% of my energy. But if it's something that I can't fix or move or change, I really just try to let that go and move with it and move forward with it. But that's helped me a lot.
Well, thank you. I think there's a lot of wisdom in that, and I think it's very helpful for all of us who are looking for, basically stop looking for that magic spot.
Yeah.
Just,
but don't stop exercising.
But don't stop exercising.
We were just joking, you know how they say sitting is the new smoking. Now I do know, and we've got some folks from our team here, I'll talk on the phone on my cell phone, but I'll pace in circles as I do it.
That works.
So I'm probably getting some steps in. It's the little things, right?
That's it.
But yeah, haven't been on a long run in a long time.
Healthcare is an incredibly demanding job. I mean, anything in healthcare is incredibly demanding. And because it requires a lot of dedication, many times people are drawn into this type of work. What drew you into working in healthcare?
Gosh, there are probably two things. First was high school. I'm going to guess every one of you has a story like this, right? In high school and in health class, if you got an A, we got to go down to the University of Minnesota and watch surgery. And I got to see open heart surgery from back then, you know, the dome up above. And that was just, wow. That was, I don't know what happened in that moment, but I was watching one human being caring for and saving the life of another human being. And somehow that was just a lightning strike. I wanted to be a doctor, and somewhere along the line, someone convinced me I wasn't smart enough to be able to be a doctor. That math and science thing, no, you know, you're not gonna cut it. I listened to that voice. I regret sometimes that I listened to that voice. And then the second was when I went out to Washington, D.C. I mentioned I was working at the Congressional Budget Office, and I began, simply because no one else wanted to do it, I started working on this bucket of healthcare issues, the orphans that nobody wanted to work on. And that passion just came back again, and I knew I wanted to work in healthcare full time. And I went to some of my colleagues on Capitol Hill, and at that time I said, who's the best in terms of healthcare policy here in Washington, D.C.? And they said it was the American Hospital Association. And that was my second walk-in, could I please work here? And it's just been a gift. It's been a gift. But I know you all have your own stories about your passion and what got you involved in healthcare. I am so motivated every day that we have the opportunity to represent people helping people. And that's what hospitals do. And so I love it.
Well, and I think understanding, and I really appreciate you sharing your story, because you're right. I think all of us, I should say, have those, and staying in touch with those actually helps motivate you through those rough times. So speaking of rough times, and I'm being a little bit tongue-in-cheek, it's been a year. Wow. So what surprised you about coming to California?
Oh, gosh. Yeah, I said it's been a year. It's been 1 second. It feels like just a flash. More surprises than I thought. All right, first, the geography, right? I mean, we're all, right, we've all gone to grammar school, and you look at it on the map, wow, it's enormous, right? It's an enormous state with an incredibly diverse geography. I'm still working my way. I obviously haven't been to all parts of the state. But even the needs of our members. I was on the phone just last week with one of our critical access hospital members who, while he is 60 miles east, in this case of Fresno, it's 6.5 hours to get to Fresno, because you forget about those mountains, right, that are in between. And they're basically 2.5 to 3 hours from the next nearest provider, which just makes you understand how vast this state is. So geography is probably one. Second surprise, the politics. So I came from a blue state in Maryland. I don't think I understood what blue was until I got to California. Just a deeper shade of blue. And with that combined with ballot initiatives, something that I have not experienced, something I certainly heard Dwayne Donner talk about year after year after year. Oh my gosh, who decided that voters should actually weigh in on real issues? So I say that tongue in cheek, of course. But the abuse of that ballot initiative process is really eye-opening and far more surprising than I anticipated. Also surprised, I think, that I came with an assumption knowing that California had a significant penetration of managed care, right? That's the history, that's what everybody understands coming into California. And while there is a deep penetration of managed care, I am surprised that there is perhaps less alignment among and between providers that I see compared to other places in the United States. I would have guessed that with managed care and such a high percentage, we'd see some greater alignment. And that's also where some of the barriers to alignment, legislative barriers, right, regulatory barriers to creating that alignment exist. So, and did I mention the weather? I mean, I had heard, but this is really great. We were talking last night about beaches that I haven't yet seen. What a beautiful place to call home. What a beautiful place to serve. So it's amazing.
Well, we're very happy you're calling California home. So thank you very
Thanks.
much. So now a little bit more on the business side. So rate setting has come up in your first year. How is it structured in Maryland, and what are some of the possibilities that you see for California?
Yeah, so I came from a very unusual state. The state of Maryland is the only state in the United States that has a Medicare waiver, right? We think of waivers, we talk about waivers, but they're all Medicaid waivers. The only state with a Medicare waiver. A state with a 40-year history of what's called all-payer rate setting. And what that means is there was a 7-member commission in the state that determined how much every hospital in the state was able to charge for their services, right? So a lot of power invested in 7 people who determined if you're hospital A, this is how much you get to charge. If you're hospital B, this is how much you get to charge. 40-year history of doing that. It grew out of, and I still believe it is a very egalitarian system, it grew out of the uninsured, where people were paying a certain price, but if you didn't have insurance, right, you were paying 2 and 3 and 4 times the price of care. So by having an all-payer rate setting system, they sort of equalized the hydraulics. And more than just the uninsured, that meant that Medicare couldn't pay less than cost. Medicare had to pay the rates set by the state. Medicaid couldn't pay less than cost. Medicaid had to pay the rates that were set by the state. And therefore, you weren't trying to figure out how to cost shift that government underfunding. And so commercial insurers weren't paying these extraordinarily high rates. They too were paying the rates set by the state. And the uninsured weren't being at least asked, even if they didn't pay, but asked for these high rates. They were paying the rates set by the state. It provided some tremendous opportunity in Maryland. First of all, there are no public hospitals, as an example, in the state of Maryland, because there was no government underfunding. And therefore, any patient can go to any hospital, and the hospital is fairly compensated. So you don't have kind of this patchwork quilt of financing mechanisms to try to make up that difference. And then what Maryland did just about 6 years ago now is moved from an all-payer rate setting system to something called global budgets. So think Canada for a minute. Hospitals are no longer paid per patient in the state of Maryland. This is the mind-blowing part. Literally, every hospital receives one amount of money for the entire year, a budget, to serve everyone who comes through their doors. And that was the game changer. We often talk about social determinants of health, and you're going to hear from Randy Oostra shortly. I'm so pleased you're here, Randy, a colleague of mine on the American Hospital Association Board of Trustees. What happened in Maryland overnight is when you changed the financing model to be a model where the hospital gets one amount of money, but now if you can keep people from needing hospital care, you get to keep the difference. Completely different incentive. And overnight, hospital organizations in that state began to use their funds to stand up community-based organizations. So they were investing in home health care services and community health workers and Meals on Wheels. And they started sending their senior team, their managers, into those organizations to strengthen them and to embed for a while. They began sharing data. They began meeting collaboratively, because if you could care for a patient and keep them well before they got sick and needed hospital care, it was now in everyone's financial best interest to do that as well. So an extraordinary model. Let me pause and say, so what does that mean for California or for the rest of the United States? I do think it is a model. Probably wouldn't look anywhere else like it does in Maryland because it has been said by the federal government that they might not ever give out another Medicare waiver again. So can you create something similar? We have been working over the last year, and many thanks to Ann McLeod, who is here for her leadership. We, as the California Hospital Association, are looking at how do we create a proactive agenda, not just what we're against, but what we are for. Ann is leading that work for us, and part of what she's looking at under that agenda are there new payment models we should be considering, new things we should be experimenting with? Should we in California be first in line to get some waivers to understand how we can shift the incentives in a way that creates healthier communities? So we are investing in that work on behalf of all of our members across the state to see if there are some new and different things that we can try. We'll see. We'll see. We'll see.
Very good. Started answering this question anyway. What do you see as the top priorities? 2019, 2020. We can never have just a single year of priorities.
That's
of course.
Right. That's right. And of course, you have a million issues. And as your team of associations, whether that's the Hospital Association of San Diego and Imperial Counties, our two other regional organizations, or CHA, we will work on those million issues for you. But we have started, we're just putting the finishing touches on what we think the agenda looks like for the coming year. And then we've got a broader one for the coming years. But in the coming year, first and foremost, we are going to be in the middle of a discussion around affordability. One of the things that we're trying to do as your association lead in Sacramento is shift the conversation. Right now, the conversation's about cost containment. And that means there are lots of eyes on healthcare in particular, looking at how we should be cutting payments to hospitals, cutting payments to physicians, cutting payments to skilled nursing facilities. We need to shift that conversation to say it's not just about cutting, it's about making care more affordable. And just as an aside, we had a bill, many of you may know, last year in the legislature that they said was rate setting. In fact, they said it was Maryland-style rate setting. Believe me, it was not. But the way they were going to make healthcare more affordable was to simply pay hospitals less. And as I look at that, and I said this in the hearing room, I said that's like walking into a restaurant and you get a check for $20 and you leave a $10 on the table. Well, yeah, it didn't cost you that much, but you did nothing to affect the underlying cost. We need to shift that conversation from we as the state want to pay less to we all together need to look at how to make care affordable. And I think about that in at least three tiers. There's the cost of the inputs to creating care. You all know this well, the pharmaceuticals, right? The MRIs, the labor costs associated with what we have to deal with. Then there is the cost of hospital physician provider care. What more can we do? to eliminate duplication, eliminate the waste if it is there, provide care, and try to get out to treat patients when they are healthy, keep them healthy before they need that acute care. And then we've got the insurance tier as well. And so affordability on the part of consumers is often viewed through that lens of how much is it costing me, both my insurance premiums and my out-of-pocket costs. We're working in Sacramento to make certain that our elected officials see that entire framework. And as an example, if we can make sure everybody has coverage for the care that they need, that will make care more affordable, right? Fewer emergency department visits, more primary care visits. If we can ensure access to behavioral health, I won't even get started there, I'm very passionate about that. We can make care more affordable. If we can keep people healthy and more stable and out of crisis, it will be less costly. So there are many things we can do. So affordability is top on the agenda. Behavioral health is right there as well. We are very fortunate in our governor-elect that he has already stated that behavioral health will be a priority for his administration. That's terrific. And we've had a role in making certain that he saw that opportunity. We're very pleased with that. Cherie Lowe is here from our team, has been doing outstanding work. There will be a statewide conversation. And it's not only about the gaps in our delivery system. You all know we have a fragmented financing system for behavioral health. Financing issues, we have an opportunity to get some of our Proposition 55 funds. We're going to be fighting 340B drug discount changes, not at the federal level, but at the state level. We've got a number of issues that we're going to be wrestling with. And as always, we've got workforce issues. How do we take the folks that we have available to us and make certain they're practicing at the top of license? And how do we use things like telehealth to expand that workforce? And then, of course, we've got a series of labor issues. And closing out, we're sort of working on 6 buckets right now. Statutory and regulatory modernization, a big on that list. The seismic 2030 standards, right? We're coming in to finish on 2020. Hundreds of billions of dollars that need to be invested on the part of the hospital field in the next 10 years to get us 2030 ready, which we believe it's time that we revisit that standard. We understand whether it's appropriate. That standard was put in place 24 years ago. So time for some modernization of how we're thinking about some of these concepts. So that's just a little peek into, into 2019.
A very, very full agenda. And you already touched on it a little bit, influenced by opportunities that present themselves to tell the story, right? Well, we've just had a pretty significant change in our midterm elections. And federally, of course, and I think we're all aware of that, but also some changes in the state legislature as well, which may not be as apparent. Would you share what you see as the challenges and opportunities that we have with the change?
Would be happy to. Let me start at the federal level. And we were talking about some of this yesterday with the board. Sort of the big event, right, was the flipping of the House of Representatives to Democratic leadership. And that's a big deal, not because there is any favoritism for one party over another. I like to think of healthcare as not even a bipartisan, a nonpartisan issue, right? We all need it, and we need to work with our elected officials no matter their party of interest. But it's a big deal because that now means divided government. And divided government is important, I think, from our perspective, because it tends to slow things down. And that's a good thing. Sometimes when you have single party control, you've got ideas that come and flash and run, and that can make for not so good public policy. So it's slower. Now, if that's good news, the bad news is that may end up as gridlock, and it may mean that we don't address anything. So we'd like to see movement, not gridlock, and we're going to be watching for that right balance of good and bad in the flip there. Good news perspective, we're probably not going to be hearing about repeal and replace of the Affordable Care Act anymore. That's been so important to us as a hospital field to make certain that we get coverage for everyone, so that is clearly off the table. 340B drug discounts, cutting those at the federal level, that will be off the table with these election results. The two things that we are likely going to be hearing more about, prescription drug price controls. That is a bipartisan issue, and we expect that we're going to see that moving pretty quickly at the federal level. And then just a series of additional oversight, accountability measures. We expect that we will see much more action and attention as both parties want to make certain that the dollars we're spending in healthcare are well spent. So that's a little bit at the federal level. At the state level, you all know we have a new governor, a governor-elect, and that does change things. Not only will this governor-elect, and he already is, quickly moving from campaign mode to governance mode, and those are two very different things, but we have some tremendous opportunities there. We have talked about behavioral health being a priority of his. Single payer, something we have been very concerned about as an association on behalf of the field, is something from which he seems to be stepping back. That I think is part of going from campaign mode to governance mode, where he has, yes, the support of the California Nurses Association, but also the California Hospital Association, the California Medical Association, the insurance plans in the state. So has to really move to a different place, likely on that issue. I think there's going to be a lot of talk about Medicare for all. That is where I think the Nurses Association has moved, not only at the state, but at the federal level. So more to come there. And we've seen, obviously, here in the state of California, a loss of the number of Republicans elected in the state. We went from 25 to 20 in the Assembly, and we've seen losses in the Senate as well. Again, as organizations who tend to prefer divided governance and government, we will have to work not only with the Republican leadership, but also with the no-party preference views and voters in the state to make certain we continue to have good balance. So those are just some of the things.
So it's very complicated, very tricky, even it could actually increase the uncertainty, particularly as we're trying to figure out what happens at the federal level. We could add on question, how do you see California helping to address the national hospital issues? We are very, very large. We have a lot of people we take care of. How do you see in this environment, how do you see California not just helping California, but the rest of the country?
In a couple of ways. Obviously, we have some pretty important elected leaders here in the state of California in both Kevin McCarthy and Nancy Pelosi. Both are, again, watch the newspapers, right? Both are, again, up for leadership positions, majority and minority. That's always helpful to us. Democrat, Republican, always helpful to us. So California will be important nationally because of those leadership positions. California is also important because we have a heck of a lot of elected officials that come from the big state of California, and that means we have influence on key committees. We will have influence in hearings and other places. And I also think California is important and will be important, especially as the Democratic Party is taking a look at its future. I think many of you know that in the primaries this year, the number of Democrats, it was about 2/3 to 3/4 of the Democrats in the primary were actually to the left of Mrs. Pelosi and to the left of my friend in Maryland, Steny Hoyer. So when you think about the party and how they are looking at themselves, we have an establishment for which we now have a large number of candidates who are coming in as progressive Democrats. And I think all eyes will be on California to see how that plays out here, to understand implications for 2020 in the presidential election. So we are definitely a bellwether. Now, some folks say, really? Kind of it's crazy out there out west, but they are always watching us. So we will have leadership opportunities and all eyes on California.
Sounds like you're in the right spot, right? I mean, it really, this is These are very interesting times.
It
Very, very
really
interesting
is.
times.
And just think about a new governor, a new administration, right? It's been 8 years, new relationships, new opportunities, new issues. Everybody's starting with a clean slate. So we're pleased to have already begun to build those important relationships.
So with your experience and with seeing things from the East Coast lens, the federal lens, the state lens, if there were 3 things that you would change about healthcare in California, what would those be?
A magic wand?
Magic
They
wand.
don't have to be...
Magic wand. This will be your magic
right,
wand.
They don't have to be easy to do. Let's see. First thing I would do, not just for California, we've got to figure out a way to rebalance government funding in healthcare. These Medicare and Medicaid payment shortfalls, Medi-Cal here, it's just not workable. And the thought that we are going to be able to continue to shift those unfunded government costs onto privately insured individuals, right? Everybody's at the breaking point. So my first magic wand would be to wipe away that underfunding. So how hard is that, right? That means the federal government has to spend more to cover the cost of caring for a patient. State government has to spend more to cover the cost of paying for a patient. And now here's the hard part for us. Anything and everything we can do to bring the cost down. So if we can get payment up and cost down, is there a sweet spot where more of the work that you do is actually reimbursed? So that would be my first magic wand. My second magic wand, here in California, it used to be funny, and now it's not funny. My first week, as folks talked about my favorite acronym, CDPH, right? And just the incredible backlog. I kept saying, like, what is this CDPH thing? Everybody's mad about it. And Title 22 was right on the heels of that. My second magic wand, for a state this size, and the 40 million people that you care for, we have got to have a state that modernizes its rules and regulations that allow you to provide care in the 21st century. It's crazy. It's crazy, and it's one of those classics. It's such a huge undertaking that no one really wants to grab it. So we've started, and we're grabbing it, but that would be my second magic wand. And my third, so this one does come from the heart. I would see us in California take the lead on behavioral health and issues of homelessness. You all are going to be talking more about that later today. I do believe in my heart that we will look back on this time and we will wish that we had done things differently. The analogy I use is the Americans with Disabilities Act. And we probably remember when that was passed. And many people said it's too expensive, it's too costly, the accommodations are too great. And now we walk into restaurants and Americans with disabilities have a place where they can sit. And restrooms, places where they can take care of their needs. And I do believe, and one of the things so striking in moving to California, obviously just because of the weather, the sheer numbers of Californians, of our citizens who are in deep need of help and assistance. And I know it hurts all of us, but we walk by. And if I had my third magic wand, it would be to immediately erase those challenges and make certain that those folks had the broad set of services that they need. Absent the magic wand, we're going to do the hard work to see if we can make a difference along with all of you. How do we look and think about something like homelessness really as a comorbid condition, as something that the people we have the privilege to treat need help with? And yes, it's all costly, it's all expensive, but how do we make a difference in those people's lives? Those would be my three.
Thank you. Those are big
Thanks.
three.
Thanks.
Well, I think we have time to open it up to the audience for any questions that you might have.
You mentioned that behavioral health will be a big focus for California in the coming years. Can you describe some of the things that you did in Maryland that were really cutting edge and that pushed the envelope for behavioral health there?
I wish I had more. I wouldn't have said that Maryland was on the cutting edge of behavioral health. What I will say is having moved to that global budget financing model meant that we needed to make certain we had our eyes on folks with behavioral health needs, because we all know they end up in two places, right? Hospital emergency departments and jail. And so in an effort to try to really say hospitals are for those who need to be there, there was a more conscious effort. In fact, I was just reading the other morning, there are more beds opening up, more community activities opening up. But it was the simple things. In Maryland, we had hospital organizations, through no fault of their own, who didn't realize the whole array of community-based resources that were out there and available, and the opportunity to partner. And so when the incentives were aligned, we saw even more active engagement with community partners, ways in which, and we all know sometimes it's just literally the people in your organizations, and do they know the people in those organizations? How could we create those ties and make it happen? It will be far more difficult in the state of California, where so many of our behavioral health dollars are sent directly to 58 different counties. And as a colleague of ours has said, if you get on a bus in the northern part of the state of California and take that bus ride to the southern part of the state of California, what kind of behavioral health care you get depends on where you step off that bus. So the need for greater consistency of service availability. So we've got the acute care piece, right, solid. It's in our hospitals. But we're doing so much more, because what we're missing is all of that in-between continuum of care. And the community-based services are often there, but only from 9 to 5, Monday through Wednesday. We've got a huge job to do to fill in, identify, right, what we have available, identify what's missing, and begin to fill those gaps. But I think with a governor-elect who sees the challenge with this issue and the need for us to treat behavioral health issues the way we treat somatic health issues, that we have a soapbox and an opportunity to get people thinking differently. Carmela. Thanks for that question.
Hello,
I'm
you? Renee Novo with Alvarado Parkway Institute. Yeah. And earlier this year, we were part of a behavioral health action coalition that took place in Sacramento. Thank you for being a part of that and championing it for us. My question is, what is the next steps in terms of local action and galvanizing conversations with our local leaders around moving the behavioral health conversation forward here in San Diego?
Yep. Let me first take that from the perspective of the coalition. If you're not familiar with the Behavioral Health Action Coalition, please go online, take a look. Governor-elect Newsom joined us in San Francisco for an event that was amazing, and there's great sort of video footage of that, and you can see him himself saying that this is just a top priority. From a coalition perspective, we're looking at two things. We've got 50 plus statewide organizations, which is our strength, right? And we've said we're all about three things: elevate, educate, and innovate. So we're elevating the issue on a statewide basis. We're educating people about the challenges, and we're looking for those best practices. How can we take the innovations that are out there and bring them to California? So one of our first next steps is around transition to the governor-elect. He has said this will be a top issue. We're going to help him with those ideas and concepts, and we hope we can do that broadly across 50 organizations. Now, we are 50 organizations who have traditionally not agreed on the best path forward for behavioral health, and that inaction has been a challenge. We've come together to say we can start here, but we hope we can move to some policies as well. The next step for the Behavioral Health Action Coalition is taking a page out of the Orange County playbook. And that is, in Orange County, actually CHA's board chair is co-chairing that effort in Orange County. He said we have 3.2 million people in Orange County, and we had 12 crisis stabilization chairs for 3.2 million people. They have spent the last year coming together, convening, bringing all those stakeholders together, asking the right questions, and now they are about to build their first behavioral health hub. They're going to look at 4 of these in Orange County. But the action was the convening. The action was bringing all of the stakeholders together, including the county and the public health officers and the criminal justice system and police and others, bringing everybody to the table to say, what can we do together? What we'd like to do is to take that convening, that workbook, if you will, and make it available to other counties in the state where they will count on you as hospital leaders, as large organizations, to step up and play that leadership role. So we hope we can feed sort of a grassroots effort across the counties to lift this issue as well. And then beyond the coalition, of course, we as the California Hospital Association will be advocating wherever and whenever we can, including additional funding and streamlining some of the challenges to getting patients the care they need.
Hi, Carmela. My name is Dasha, and I would like, first of all, sorry, I'm going over here so that not too many people have to turn around. I, first of all, would like to thank you for continuing to talk about behavioral health and also recognizing that mental health is not the only concern, that there's also substance use and that's what makes behavioral health an issue. I'd like to talk a little bit about homelessness. So one, I have spent a number of years and still am in behavioral health field. I live in downtown, so I see homelessness firsthand. A proposition, and forgive me, I don't remember if it was a measure or a proposition, just passed to allow for transition of some of the funds from Mental Health Services Act into the No Place Like Home program in order to subsidize some of the housing initiatives and to place those who are homeless and need services into housing. And we all know that housing is in a way, a number one concern in order to get those who are homeless into services. However, I think it is a gross misconception to think that putting homeless into housing is, in a way, a low-hanging fruit. I disagree. I think that, in a way, it is a lack of understanding of just what the homeless need or want, and there are plenty of homeless who are not housed for a reason. They don't want it. They're scared of the government, they're scared of the system. And in a way, this is a two-part question. One is, what are some of the strategies you feel you will be developing and working with Governor-elect Newsom to try to develop in order to figure out how to place those who are homeless into housing and try to destigmatize the government among the homeless population, but also how are you going to mitigate the funds that are now being taken away from Mental Health Services Act and other mental health and substance use programs into the housing initiative?
First of all, thank you, and thank you for what you do. Thank you for your passion. What you've just illustrated is what we all know. I mean, this is an extraordinarily large and complex issue, and to your point, there is no single solution. And how do we make certain that we are not simply taking out of one pocket to put in another pocket? Does that really help us overall? So I'm going to answer very broadly, but happy to talk more specifically later. Very broadly, it's part of this education piece. And to your point, we have people who are living on the streets who have rights. And that may be exactly what they want and where they want it. And I think we have to be more sensitive to understanding the complexity of those individuals. We want to make certain we care for their needs. While there is an overlap, as we all know, between behavioral health and homelessness, it is not a 100% overlap. And so we have to know more, and we have to understand that you can't paint a picture of this population with a broad brush, that the homeless population is as diverse as the population with homes. And I think your second point is, how do we make certain we don't fall into what sound like simplistic solutions? Now, I do have a dear friend who runs something called Healthcare for the Homeless in Baltimore, And he says the answer to homelessness is homes, but of course it's not that simple. So housing is clearly a piece of this, but we have housing, we have behavioral health needs, we have issues around jobs, right? Some of the innovative practices around the United States, when we're looking at what these behavioral health hubs should look like, it's about vocational training. How can we make certain that we're not only dealing with people's immediate health care and risk needs, but it's about poverty, and it's about making certain that we can find jobs for individuals and lift them out of this state. So I'm going to take your question, which is, we've got to help people understand. The coalition will help to educate. It's not simple. It's not straightforward. And this will be a years-long set of solutions. My worry, however, is that if we fight about what the initial first step is, we're never going to be able to make that first step. And that's sort of been the tradition here, that if the solution doesn't meet everyone's needs, no one wants it. And I think it may be time for us to think differently as a coalition. This might not be my idea of the first best step, but it's a step that needs to be taken. And if it's a step that can be taken now, let's start and let's create that movement. Thank you so much.
This really is the last question this time. I'm Jan Spenceley. I'm with Stand Against for Healthcare Coverage. We're a community-based organization, and we work closely with hospitals and the Hospital Association. My question for you is, you've kind of talked about it and around it, and I guess we're going to hear more about it today. But I'm a follow-the-money person, and how do we address that issue? Hospitals and their role in addressing some of these social determinants of health, which you can't separate from behavioral health. You can't separate from hunger. You can't separate from housing. You can't, is the hospital role in driving for that? And I think it's a challenging one, but because I think that there are payers involved as well. And how do you see the Hospital Association sort of taking a lead, I hope, on bringing the right people together in the future?
Thank you for the question. I think we have an opportunity, as we're doing, for example, on behavioral health, but even the work that we are engaged in around other types of social determinants of health. I think as an association at the state level, we have an opportunity to model that convening, and we're doing that. This association here in San Diego has the opportunity to model that convening, and then it's really about organizations in your communities doing the same. I get it, and there is so much more I'm certain we all want to do in our communities, but we have financial limitations to what we can do. I do think that we are at a point in time where we need to be as creative as we possibly can. One of the things that I'm experiencing in this new role at CHA is about new partnerships, reaching out to organizations we haven't worked with before, but where we find ourselves aligned. Maybe it's just on one issue and not every issue. How does that play out at the local level? Are there partnerships that are non-traditional that can help us resolve some of the issues that we need to in our community? What I am certain of is the leadership in this room is the leadership it takes to make a difference. I'm so excited you're going to hear from Randy in just a moment, and the leadership that was provided at his organization in his community to do something like food insecurity screening for every individual. It can be done, and I think we're all going to be taking a look at how do we balance what we must do, what we can do, and continue to balance that with the needs in our communities. It's not easy, absolutely, but I hope that we will begin to build broader coalitions. We've got one on behavioral health. We're so excited about it. Where do we go next to really bring that power together and try to create change? Thanks.
Well, Carmela, I want to thank you very much for your time this morning. Your experience, your passion, your leadership and vision is exactly what we need in California to help advance care for all Californians and to ensure that we all have places to care for people and that those survive, and not just survive but thrive. I thank you very much for your time. This is a very exciting time. Glad to be working with you. I'm glad you're here. And I think I speak for everybody that look forward to your leadership in the upcoming years.
Well, thank you, and thank you, Jane, for your leadership. This was almost as if we all had breakfast together. I wish I could have the opportunity to come and have breakfast with each and every one of you, but thank you for listening a little bit and learning about me. Thank you for your leadership for this association, and to all of you, a deep and sincere thanks for the work that you do in your communities. It is unparalleled. Thanks.